like to introduce our speakers for today. First, Dr. Mary Fallett. She is a professor of surgery, pediatric surgery at the University of Louisville and Norton Children's Medical Group. She has been our surgeon in chief for over 20 years before stepping down a couple of years ago, and recently has led our endeavor in obtaining Pediatric Surgical Center of Excellence verification with the American College of Surgeons. Dr. Fallett completed 2 terms as a member of the National EMS Advisory Council representing the trauma sector and was a member of the ACS Committee on Trauma, and is currently the immediate past vice president of the American College of Surgeons. Dr. Fallett has been funded by HRSA as a program director for Kentucky EMS for Children since 2004, and she serves as a trauma advisor to the HRSA EMS Innovation and Improvement Center and to the National Pediatric Readiness Program. She is a sub-PI for a HRSA grant from the National Pediatric Pandemic Network that we will be talking about today. Next, Kenneth Kirk is a former critical care and flight paramedic with 35 years of EMS, rescue, emergency preparedness, and emergency response experience, including 20 years as a firefighter, paramedic with the Nashville Fire Department, and 15 years with Vanderbilt University Life Flight. He is retired military with 12 years active duty and 10 years in the Air National Guard. He joined the Kentucky Department for Public Health as the Bluegrass Healthcare Coalition Coordinator upon retiring from the Fire Department in 2018. And since May 2020, he has served as the Kentucky Healthcare Preparedness Program Manager. Next, Angela Kick is has 30 years of experience in emergency and intensive care nursing and 11 years of domestic and international flight experience. She earned her nursing degrees from Midway University in Kentucky, and she was previously an emergency room director and trauma director for a level 3 trauma hospital and served as the chair for Bluegrass Healthcare Coalition. Angela currently serves as the operations and logistics section supervisor, incident management team lead, and is also the Kentucky Nurse Strike Team lead. And next we have Abby Bailey, who brings over 2 decades of EMS and leadership experience to her role as the Norton Children's Hub Site Program Manager for the Pediatric Pandemic Network. Abby earned her bachelor's in psychology, and along with many years treating injured pediatric patients, she has a strong interest in the mental health and pediatric trauma patients. And lastly, Dr. Karen Orman is an associate professor of pediatrics in the Division of Pediatric Critical Care at the University of Louisville and Norton Children's Medical Group. And since 2001, she has been the medical director of the Just for Kids Pediatric and Neonatal Transport Team. Dr. Orman also directs the Pediatric Mobile Simulation Outreach Program, traveling around Kentuckiana region, teaching and training healthcare providers and staff in acute care pediatric scenarios. She is the site director for the University of Louisville Emergency Medical Services Fellowship Program and the content expert for pediatric transport in the Pediatric Pandemic Network Trauma and Burn domain. So thank you everyone for joining us, and I will turn it over to you, Dr. Fallett.
So each speaker will be showing their own slides. Hopefully you can see this. So just give us a minute in between presenters, and thank you for allowing us to provide this presentation for you today. Mark gave a great introduction in just under 5 minutes, so I applaud him for his alacrity, and I'm going to move through this. As you heard, we have no disclosures. So I'm going to begin with looking at the map on the left that shows the states of rural America. Most of you know that Kentucky is one of the 15 states in the nation that is a primarily rural state. We have over 100 hospitals with emergency departments open for business, 120 counties, half of which are in Appalachia. We have 2 level 1 adult and pediatric trauma centers associated with our medical schools mostly in the upper part of the state. And then we have a level 2 adult trauma center in Pikeville with an osteopathic school. The EMSC partnership program has actually been operational in our state since 2001, and I've been involved with it that entire time, which has really given me a great opportunity to understand our state, its rurality, and how our children receive emergency care. So when this grant came along, it required the presence of at least one center in a state within both the Delta Regional Authority and the Appalachian Regional Commission. And it turns out that Kentucky has that qualification. And my colleagues reached out to me and asked if we would be interested in becoming the trauma burn hub for the grant, which is an all hazards approach to children's needs during a pandemic. And so, of course, I said yes. It really was a way to culminate a career where I've been focused on pediatric trauma. And so today our agenda is to talk a little bit about the HRSA programs for children, of which EMS for Children and the Pandemic Network are both HRSA programs. I'm going to talk a little bit about how we as a trauma burn hub expand our interests across the country. And then Ken and Angela will talk about how our grants address our home state of Kentucky. Abby is going to specifically talk about mental health triage, which is so important today because of all of the issues regarding that. And then pediatric readiness in our Kentucky rural hospitals and trauma centers will be discussed by Karen, as we got a supplemental grant through EMSC to develop that program, which really adds to the benefits of the PPN grant. First, just to orient you, on this slide, I have the HRSA-funded programs that Mark mentioned. On the left is EMS for Children, which is the way that we improve emergency care for kids across the country by helping first responders and hospital emergency departments become pediatric ready. More about that later. The EIIC is the research arm of the HRSA programs to develop strategies and help medical professionals understand how to take better care of children who need emergency care. And then the PPN network collaborates across the country with children's hospitals in their communities to provide the best care possible to children in emergencies, disasters, and pandemics, remembering that if you aren't ready to take care of a child every day, you won't be ready to take care of them in a pandemic. On this slide, I've depicted the HRSA programs, which you can see here, but this is sort of a massive undertaking, but a small part of the government. So here's the executive branch of the United States, the Department of Health and Human Services, which is where ASPR is. And these are the pediatric disaster centers for excellence, which integrate greatly with our programs. And then over here is FEMA, which is where you have emergency management. So ASPR is where the HPP, the hospital preparedness programs are, and that's what Ken and Angela are most associated with. This is a map of the pandemic network. There are 10 hospital hub sites. Here's us. You can see they're geographically located across the country. And it's a grant that has awarded $77.5 million over 5 years to these 10 children's hospitals. So the challenges in achieving high quality pediatric emergency care are really quantified by looking at where children live. And over 80% of children are actually seen in emergency departments that do not typically take care of children. And many of these emergency departments see less than 15 children a year. Oh, sorry, a day. Likewise, the emergency medical service clinicians that are in our ambulances have a pretty low chance of treating a child on a given day. If you look at all of the runs across the country, only 7 to 8% of those runs are children. And so the chance of an individual EMS clinician taking care of a child who's really, really hurt or really, really sick are pretty small. And if they live in a rural environment, it's even less, which is why it's so important that we keep teaching people over and over how to take care of kids. Pediatric readiness is ensuring that every EMS agency and emergency department has the pediatric specific champions, competencies, policies, equipment, and other resources needed to provide high-quality emergency care for children. There are over 60 published articles now on pediatric readiness. The Pediatric Readiness Program is actually over 20 years old. And these research articles give guidance to the fact that if you have a high enough score, you will save lives if your emergency department is pediatric ready. That score is composed of several different buckets, and we don't have time to go into detail today, but you need a score of at least 87 points out of 100 to be able to recognize the gain from being pediatric ready. So one of our big challenges is that many rural hospitals are down more in the 60 to 70 point range. So elevating that status by being able to contribute to their pediatric knowledge and help them be pediatric ready is one of the goals of our programs. Access to pediatric trauma and burn care in our country is also somewhat daunting if you look at where kids live. And so what we're going to talk about today in that continuum of care that includes injury prevention all the way to when a child goes home from a hospital are the pre-hospital components, the transportation and emergency department components. This is a map of the community hospitals in the United States. There are nearly 5,500 hospitals. Some of them are acute care, that 5,139 represents those with emergency departments. And of those, nearly 2,000 are considered rural hospitals. So those would be critical access, smaller trauma centers. And you can see down here, there's only 279 children's hospitals. So when you appreciate that the children's hospitals are few and far between, and a lot of them are located in highly urban areas, you can understand why access to care can be compromised for some families. So here's the map you just saw. Over here is where the level 1 and 2 pediatric trauma centers are located. Here's where the level 1 and 2 adult and pediatric trauma centers are located. And over here is where the burn centers in the country are located, recognizing that some burn centers do not primarily take care of children. However, when you look at this map, which compares level 3 and 4 trauma centers to level 1 and 2 pediatric trauma centers, you can see we have a lot of opportunity to expand pediatric readiness into centers that really are more thoroughly distributed across the country. So the trauma program through the American College of Surgeons that provides verification has a new standard as of August that pediatric readiness must be assessed in a trauma center. They must have a score, know where their gaps are, and have an approach to their gaps. And each cycle is 36 months. The ACS has become a partner in pediatric readiness. And what we're hoping is that at least for verified trauma centers by the American College of Surgeons, this will permeate the country. Having said that, this is the map of hospitals in the Kentucky trauma system. The color codes are yellow is 1, orange is a level 2, of which there's only 1. Level 3 verified and designated are this purple color. And then this color blue is level 4s. So a caveat is that level 4s are verified by our state. And currently they do not have a pediatric readiness standard. But the Trauma Advisory Council met yesterday, and we are trying to change the regulations so that will be a standard in the future. We do have 21 verified trauma centers, and we're a voluntary state, which means you become a trauma center if you have the interest and the infrastructure and the administrative support to do that. One of the other things we're doing is looking at burn care across the country for kids, understanding that everyday burn care is not rendered many times in burn centers, but in children's hospitals that are not burn centers. So we're trying to get a handle on where burn care is delivered and then work with the American Burn Association to develop an action plan if we were to have a critical emergency involving burns. We're also developing with the EIIC that evidence-based part, some one-pagers that will be able to be in smaller trauma centers, pull off the shelf type of guidelines and protocols for head injury, spinal cord injury, and other things to enable a smaller hospital to stabilize the patient before transfer. This is another thing that will be of interest to smaller hospitals. It's a manuscript that was just released that looks at a checklist for disaster planning for a surgical surge. So emergencies like this can happen anywhere. They don't always happen in urban areas. So if you had a school shooting in your area and it involved 15 kids, where would they go first? And if some of them needed operations immediately, this is a checklist that looks at the preparation of your operating room for doing that. Recognizing that there will be patients that will need to be moved and surgeons could be in the operating room, we also recognize that intensivists and hospitalists are going to be very important in terms of helping with this plan if surgeons are operating. This is a project that I did looking at pediatric trauma system development across the country. It resulted in a 250-page report. That QR code, if you're interested, leads you to the report. But we also are funded now through the network so that we can continue this project, and we're in the process of hiring a program manager. And each state gets a score up to 100 based on these domains, and each of the domains has a number of metrics associated with it, which are measurable, although we will hope to update these now that we've been through a pandemic so that we can reassess states in the future. We also have developed a pediatric sub-track in acute care surgery so that surgeons who will be doing acute care surgery in smaller hospitals where they might be taking care of some children would have an opportunity to incorporate up to 3 to 4 months of pediatric surgery, critical care, and trauma in their fellowship. So future plans are to also look at climate change and its effects, which is critical for our state, and to study those effects, to look at how the state dynamics have changed with the last survey, to be able to implement a national pediatric trauma center. And then Ken and Angela may talk a little bit about the concept of a pediatric medical operations coordination center, which we've also now been funded for. And then continuing pediatric readiness in Kentucky hospitals. So at this point, I'm going to stop sharing and Ken and Angela will take over. Thank you.
All right, there we go. Thank you, Dr. Fallett. So my name is Kenneth Kick. I'm the Healthcare Preparedness Program Manager, and I'm going to do the first part of this presentation, then turn it over to Angela. So pediatric planning in the state, this was a focus in 2019, just prior to the pandemic. And we were doing some great planning in the first part of that fiscal year. And then we kind of got derailed a little bit with the whole COVID-19. But we're getting back to that now and putting together some work groups and some stakeholder groups, and really because there's a need for that pediatric planning, as Dr. Fallett talked about. So within our healthcare coalitions across the state, and those not familiar with our healthcare coalitions, they're made up of multiple healthcare organizations and entities. So our core members are our hospitals, our acute care hospitals, our EMS agencies, our emergency management agencies, and our local health departments. From there, that umbrella spreads out to dialysis centers, long-term cares, our FQHCs, our RHCs, a lot of the clinics out there. So the networking planning with those stakeholders, you know, it's not just focused on the adult all hazards. We want to be very inclusive with that pediatric part of it. And that's why we started that networking planning with the children's hospitals, PPN, EMSC, and then of course our coalition members. So our pediatric readiness and response planning right now that's going on in the state, our healthcare coalitions, we have 8 of them, and I'll show a map of that here in just a little while. Each one of those have a specific pediatric plan annexed to their response plan. Along with that, they've tested those with tabletop exercises and some functional exercises. So that exercise and training piece is so important, especially for our critical access hospitals, in getting those involved, and that knowing that if there's a pediatric mass casualty, it's likely not going to happen in Louisville or Lexington. It's going to happen out in one of our rural areas. It's going to be, you know, a bus rollover. It's going to be something like that. And those kids are probably going to go to the closest local health hospital first. And then in a community type event, you know, we've seen some of these school shootings and other mass shootings. You know, sometimes those kids maybe just be thrown in a car and taken straight to the closest hospital. So we have to make sure that our EMS agencies and our hospitals are pediatric ready. Part of that and part of our funding is we're able to purchase some pediatric specific equipment. So we've been able to help out some of our rural EMS agencies, some of our critical access hospitals with purchasing some neonatal transport ventilators, some of the hand Tevi and Broslow products, some good pediatric crash carts. You know, we go into some of our smaller acute care hospitals and they didn't have a pediatric specific crash cart. You know, it may have been a drawer in the room of whatever exam room they use for kids, or it may be a drawer in their adult pediatric cart. So we want to make sure they had some good equipment. We don't have a lot of money. I wish we had a whole lot more money to spend on stuff like that, but we are able to help out some. So our current initiatives and future planning right now is, you know, a more formalized response relationship between the state and the stakeholders. And that's where that Pediatric Medical Operations Coordination Center comes into play. Angela's going to talk a little bit about our activations and what we do with the State Emergency Operations Center. And this is where this would come into play. And bringing this group together, so if we have a pediatric type event, how are we going to manage that pediatric specific? And we all know we have 2 pediatric hospitals here, or 2 children's hospitals here in Kentucky, but we know that if we have a large incident, these kids are going to go to Vanderbilt, they're going to go to Cincinnati, they could go to St. Louis, who knows? So we need to have that collaboration, that coordination, not only within our state, but across other states. And also the assisting with family reunification. This is a big piece of that. So this is a map of our healthcare coalitions. If you're not currently a member of the healthcare coalition, or if you're not sure if your entity's a member of the healthcare coalition, please reach out to me. We want you to help plan with us. We don't want to plan for you. So we want our physicians out there to be a part of this process. You know, you guys are on the front lines. The clinicians are on the front lines. You know, we want your input on this stuff. In planning, there's a lot of assumptions that are made at our level of what you do. And we really need that boots on the ground knowledge as part of that. And I'm going to turn it over to Angela for this part.
So I'm Angela Kick. What happens when we do have an incident in Kentucky? So I'm going to talk a little bit about how our system is activated, and possible notifications that go out, and where those notifications come into the system through. So when we are activated, and I'm talking about, we would be activated for the State Emergency Operations Center, which is here in Frankfort. We basically invite some stakeholders to the table. So we are ESF 8, which is Emergency Support Function 8. It's health and medical. It includes all the healthcare sectors in the state of Kentucky. That's who we represent when we are activated. So we invite our healthcare coalitions to the table because they are our force multipliers. They provide a lot of that communicational and situational awareness throughout the state. We also partner with our federal partners if we need additional assistance. So if we do have a large pediatric incident, we're going to need the federal partners to come in and help us with this. So how do these notifications come in? Sometimes they came in through our first responders, our local and regional emergency managers. Sometimes the local hospital will communicate with the healthcare coalition, hey, something's up. Sometimes it comes in through our state warning point, and sometimes the media. We see it on the news. I saw a bus rollover in Eastern Kentucky, was it last year? Came in through the news. So that would all indicate we need to have an activation. Oops, sorry, wrong way. So this is kind of our flow chart for activations. So we get an incident notification. Again, it comes through one of those routes into us. And then we decide, how do we need to activate? At what level do we need to activate? Dr. Stack is our healthcare commissioner. He would always be notified that something is going on. And it's at that point, if you look on the slide, that this medical operation coordinating cell would be activated. And basically that is going to be a group of basically hospitals or the C-suites at hospitals going to get together. And if we need assistance to move patients to, we call it load balancing patients, this is where that would happen at. So how do we know where our kids went? We've been talking about patient tracking for a while, but in 2018 here at KDPH, I kind of looked around and went, okay, we have not had a system that has worked well in Kentucky. So we put together a work group, and it was hospital folks, pre-hospital, emergency management, and us at the state health department. And we basically mapped out a process of how do we want patient tracking to work in the state of Kentucky. It's extremely important to understand that at the scene of an accident is where those decisions are basically being made of where our kids are going. So I'm going to show a video here in just a minute of Louisville. So in Louisville, where would you think that parents would think their kids would be taken? To Norton's Children's. But if you have a big bus accident, they're not going to take all those kids to one facility. They're going to go throughout to several different facilities where they have beds available. So we needed a system that would work for us. Thinking about, where's the patient coming from? Where are they going to? What's the triage condition of this patient? And we use the typical triage colors. So black, red, yellow, and green. And then family reunification. How are the parents going to be able to find their kids? So we also needed a system that we could scale up and down to make it useful for us. So I'm going to show you just a very short clip. Hopefully this is going to play of what this was an actual accident in Louisville. Then they did not use patient tracking.
7:15 Friday, bus number 1250 carrying 48 students and one driver to Falls Middle School is involved in a crash with a red Mustang carrying 3 teenagers. As a result of that collision, the school bus flipped over several times. Instantly, emergency crews arrived, trying to figure out exactly what happened and help everyone involved. Parents of the children arrive in a rainy haze of confusion, fear, frustration. I have a daughter and a granddaughter. This on this bus right here. They have told me nothing, but wait. Some children were even using borrowed cell phones to call for help. After crews were able to move in and start forwarding information to parents, this is what we learned. The Mustang slid into the inner.
So if you listen to that video, they were not using patient tracking. They're very busy. This is a typical scene. When there's an accident like this, it's even worse when there's kids involved. But the parents were not able to find their kids. And this is really concerning, and it happens all the time here in our state and in other states. Patient tracking is something that every state kind of is having a hard time to figure it out. So we have developed a system in every hospital, every EMS is basically can get onto this system. And it's all done on a device like a phone or an iPad. It starts there, very little information. It is pure patient tracking. But the good thing about this is that every hospital EMS then have trusted agents that then they can get onto the dashboard on a computer, and you can set up a family reunification site away from your emergency department. So you get the chaos away from the emergency department. And then you can basically find any kid. So if Norton Children's, a family member comes in there, they say, I'm looking for this child. They can look on there and see where that child went. So then you don't have to make 20 phone calls to all these different facilities. You can take pictures on the system. Everything is secure, it's HIPAA compliant. So if the child cannot speak, there's going to be able to take a picture on there, and it'll be much easier to track. We are getting some traction in Kentucky due to, the tornadoes that we had, to the flooding that we had. People are really starting to see the importance of having a system that works. And this system does work. A couple other things, and I'll let Ken talk real quickly about this Ohio.
So this past November, there was a pretty horrific crash up in Ohio on I-70. And this was a chartered bus that had high school students on it, was rear-ended, caught on fire. The news was reporting that there were 6 fatalities on the scene. Obviously, being a parent myself, you're going to have some very panicked parents, especially if you know your kid was on there. And the problem was the patient tracking wasn't started at the scene. And the kids, your lesser acuity kids are not going to necessarily come to your children's hospital. It's going to go to your local hospital because maybe it's just a couple scrapes and bruises. They don't need to come there. We need those level 1 traumas to be taken care of at the children's hospitals. So, the parents had no idea, where's my kid at? So that patient tracking wasn't started until they were at the hospital. And, parents were calling the hospitals trying to find out where their kids are at. And a lot of people, they don't have the knowledge that we have, where, they're not necessarily in the medical field and stuff. They see emergency department and they think that's automatically where they're going, or they see children's hospital and they think they automatically go to the children's hospital. They don't understand that triage system and how we load balance. But this was just one example of, why it's so important that we keep track of these kids for family reunification.
So if you have any questions, want to find out if your facility has been involved with patient tracking, please reach out to me. My email is on the screen for you. Take a picture of it real quick. And thank you.
Good afternoon, y'all. My name is Abby Bailey. I'm the hub manager here at Norton Children's for the Pediatric Pandemic Network grant. Today we're going to talk about our SciStart mental health triage program for our injured pediatric patients. So like Dr. Fallett said, we are one of 10 hub sites underneath the PPN network. And there are 19 domains underneath the network. One of those, like she talked about, is the trauma burn domain, which sits underneath our hub site here. I am the domain manager for that domain. I also sit on several other domains, including the pre-hospital domain and the mental health domain, which is how this SciStart project got started. So what we all know, and it's not news to you guys, I'm sure, is that kids get hurt. Trauma is the leading cause of death in children. Some statistics I found looking through, especially our Kentucky statistics for our kiddos here. In Kentucky in 2020, EMS agencies transported over 6,200 pediatric trauma patients to local emergency departments. And that sounds like a pretty significant number, but that's a really small number for those EMS agencies. Like Dr. Fallett was talking about, they see a very small percentage of trauma kiddos. But that's a lot of kiddos getting hurt. And those that EMS takes are pretty significant injuries. They're not the kids that mom and dad are thrown in their cars and taken, or waiting to go to the doctor tomorrow morning. So these are kiddos that have gone through something pretty traumatizing, not just that injury, but stuff that's going to stick with them. And we need to be considering what else is going on that may affect them mentally, not just the bones that we need to treat and their injuries, their physical injuries. So we need to think about their contributing factors to those injuries. You know, what was going on in that child's life, the experience of the event, the exposure to the trauma, the context of the disaster or the event in their life, and then what were that child's pre-existing needs. And you'll see how all of these things here in just a second kind of play into SciStart, which is our trauma mental health triage tool. This is all just to kind of set the scene for some things that as clinicians and providers, we probably aren't thinking about when that injured child crosses our path, whether we're meeting them on the scene or in our trauma bay, in the hospital room, wherever we happen to come across that child in their course of care. So this tool was developed by Dr. Chip Schreiber out on the West Coast several years ago. Initially was developed after a series of wildfires. It's now been used for many multi MCI situations, including Sandy Hook, the Boston Marathon bombing. Most recently, and I'll touch on this here shortly, but most recently it was stood up super quickly after the Kansas City bombing, or not bombing, excuse me, the Kansas City shooting with the Super Bowl parade. Was also used and deployed really quickly after the fires in Maui. But so real quick, and this screen's probably hard to see here, but again, it's a rapid mental health triage tool, which uses trauma risk exposure factors rather than symptoms that the child may show upon their arrival to where you're seeing them. So we're not judging based on whether the child's crying intensely, screaming and lashing out, or even just sitting still and not making any kind of outward motions or emotions. So this allows for a patient level risk assessment as well as a population level risk assessment. In the case of an MCI, when we're doing a lot of these on patients, we can kind of get a trauma threat level for the whole population or community. It's a simple, quick assessment that's evidence-based. This will take less than 1.5 minutes, 2 minutes to complete. This will also help hospitals comply with the new ACS COT standard 5.29 in the ACS Graybook. And I'll talk about that here in just a moment also. So a little more about SciStart. You saw those colors break down. SciStart's a list of about 15 to 20 questions. And the color breakdown, the purple question says, does the patient want to harm themselves or others? And this breakdown here kind of shows you how that goes. So that's obviously an emergency risk for mental health. And we're asking that anyways of most of our patients. The red question breakdown is for the acute trauma risk. These are for that incident that the child has just gone through. And those are questions such as, did the child feel an immediate threat to their life? Did the child experience or hear the death of a loved one, of a friend? Did they experience the death of a pet in the disaster? Items such as that relate to the immediate tragic event or traumatic event that the patient was involved in. The yellow questions are along the lines of, did the patient have a mental health prior history? Is there evidence of abuse or neglect in the home? These allude to the social determinants of health and chronic risk factors. And then the green at the bottom says that none of these applied to our patient. And those are no risk factors identified, like you can see here. And those are just important for capturing that overall risk. So this is that the 5.29 that I was talking about earlier. This is in the new resources for optimal care of the injured patient from the ACSCOT. And what this says is that patient, all level 1, 2, and 3 adult centers and 1 and 2 pediatric trauma centers need to have a mental health screening and referral protocol if you're a 1 or 2, and that level 3s need to have a referral process. And this is that when your injured patient comes in, you need to be able to screen them for mental health, and at level 3, be able to refer them out if they've screened and you can't treat them in-house. So SciStart's an easy way to help meet this standard. What we've done here at Norton Children's, in part of the PPN SciStart Collaborative 1.0, which was took place last year, we established our SciStart program in the middle of June. We began in our ER. We also started with EMS here in the Norton area with the EMS systems here in Louisville. But all 10 of the PPN hub sites are now on board with EMS or with ED SciStart. So what they're doing is, as any traumatically injured child comes into the ED, they're getting a SciStart assessment, and then patients that screen with 2 or more in the red boxes, those children are getting a consult, a site consult while they are in the ED. And if that leads to more, then they're starting those that treatment while in the hospital rather than delaying that. And the idea behind that is that if we can catch these kids in their peri-trauma period within the first couple of weeks after their traumatic incident, then we can prevent the PTSD and other issues from starting down the road, thus lessening the problems they have. So we started on paper here at Norton's, which we know is not ideal. And in the last 6 months, we've been working really hard through the PPN to figure out a way to incorporate SciStart into Epic. And we're super close. We've got a group that is beta testing it right now. So hopefully here in the next couple months, we'll get that up and running. And the paper thing has been a little rough. We started out, we had 50% completion rate within our first 2 weeks. That did drop down some. We were doing it in this binder that you see here in the picture, which was hard. It wasn't the easiest for the nurses to do, or EMS for that matter. In September there, you can see we had a big bump in our completion rate. We changed where the forms were held. So rather than forms being in that binder, we had moved them to in the bags with the trauma lab vials, the blood draw vials. So just by placing them in a place that was more convenient for the nurses to get them, I think it made a huge difference. Our numbers for January and February this year are back up right around 50% completion rates. And the ED is taking that on this year as their big project for 2024. So we are here to help them, and we appreciate all the hard work that they're doing in the ER to really get this up and running and incorporate it to help the children with their mental health after these issues. So the EMS side of it, in the PPN mental health, in our pre-hospital domain, we've discussed that EMS may be better suited to complete this form since they're on scene. They see what the child kind of went through in real time. The SciStart is not designed to be asked. So those questions are not designed to be asked of the child and bring up all the past trauma again. So therefore, we think that EMS is in a particularly good spot to answer those questions instead of the nurse who's getting all the information second or third hand. So we rolled this out again last summer. At the time, we had 7 agencies participating. We now have 8. EMS was really excited. They saw the value in this and really understood what their role was and why they could be so helpful. At the time, we weren't getting, we're still not right now getting the information from the older patients who go to U of L, but U of L is very interested in joining on also. And we've got new ideas brewing to figure out how better to get EMS to be able to complete their forms en route to the hospital, which we think will also be a big help and get more completion rates from EMS. So it's still a work in progress, but working every day to develop this as it goes and kind of improve what we're seeing there. Future projects, we'd like to bring on some more Kentucky hospitals and also more EMS agencies across the state. Eventually, we'd like to see this as a standard practice for EMS and ED trauma patients. There's been talk with the state mental health group about including this in their disaster planning, state disaster planning. We've also had interest from police department for use, definitely in the future, but for use on children that are on scene of domestic violence calls or shooting calls where the child's not injured and would have no reason to go to the hospital, but has obviously been affected by a traumatic event and could possibly use some mental health help for what they've been around. To touch real quick on what's going on in Kansas City. I was on a meeting yesterday and we were discussing our side of the EMS portion of this. And the hub manager from Kansas City said that they have been working on expanding their SciStart program in the ED there and had talked about doing EMS. But after the shooting, they had 11 children that were shot and had come into the ER. However, they know that there were a lot of other children that were at that parade and then again in the school systems and in the communities involved. So they have very quickly set up SciStart in community pediatric practices and other offices around the Kansas City area. Schools included, to try to help those kiddos that were not physically affected, but clearly will have some issues and some problems just by the fact that their friends may have been, or they were in the area, they know about what happened. So it's really cool to see that this is a project that can come together quickly in a time of need to help our kiddos and how it can develop, like I said, super quickly, but also in a really practical manner. So if you're interested in any more information on SciStart or how you could get involved, my information is up here on the screen. Like I said, it's an evolving project. We've got new kind of things coming out. So if you had any ideas about how we can improve any of what we're doing while this talk was going on, I'm also more than happy to hear those out. So I will stop sharing and turn it over to Dr. Karen Orman.
All right, my name is Karen Orman. I'm going to talk about the Kentucky Pediatric Readiness Simulation Program that we have developed here at Norton Children's through a grant that Dr. Fowlett is a part of. She already mentioned the National Pediatric Readiness Project, the initiative funded by HRSA through EMSC that supports emergency medical services, fire and rescue agencies, and community EDs in their ability to provide high quality acute care for children. Part of that initiative is the calculation of the Pediatric Readiness Assessment Score. Dr. Fallett mentioned that having a higher score is better, and having a score over 87 can lead to improvements in mortality for children. The last national survey of US EDs in 2021 had a median score of almost 70 out of 100. So we have some room for improvement across the country. This is also just some of the metrics that say that higher score leads to significantly lower mortality in both ill and injured children. So Kentucky is one of 18 states that has a certification program for their facilities to get emergency care recognition in pediatrics. Those certifications are based on the NPRP, the 2018 Joint Policy Statement entitled Peds Readiness in Emergency Departments, and then several EMSC performance measures for medical and trauma emergencies in children. It looks at, when they go out for site visits, the administration as it relates to children, the staff qualifications in the ED, patient safety, quality initiatives, and then having pediatric specific policies and supplies and so forth. That site certification, Dr. McDonald, who's our moderator today, is one of the certifiers, as well as several people in the Norton Children's Hospital ED, including physicians and nurses. Currently, there are 11 hospitals throughout the state of Kentucky that have achieved that site verification. They keep it for a period of 3 years and then can recertify. And those hospitals include Norton Children's, Kentucky Children's, the Ephraim McDowell hospitals, Taylor Regional, Pikeville Medical Center, so hospitals throughout the state. Kentucky also has a voluntary EMS pediatric recognition program that uses some criteria established by the state that go beyond what the EMS may already do for pediatric requirements. The graphic there shows the EMS and fire agencies that are currently recognized through that program, and the red boxes are the ones that are fairly close to Jefferson County, where Norton Children's is. So our simulation program evolved out of some funding through EMSC State Partnership Rural Expansion Program grant that Dr. Fallett and Morgan Skaggs at the state EMSC program helped to get for us. The goal of our simulation program is to provide in-person simulation for level 3 and 4 trauma centers and critical access hospitals that are preparing for that site verification visit through the Kentucky program. Initially, the grant thought that they would get maybe about 7-8 centers, but finally they had a robust 22 centers that wanted to participate in our simulation course and go through the didactic assistance to get site certification. 12 of those centers were critical access hospitals, 8 were level 4 trauma centers, and then there were several that had kind of a between designation. Here's a map of where all of the centers are that participate in the grant across the state. Kentucky Children's Hospital with UK created a mirrored program with ours, and so we partnered together to try and get the simulation course out to all of these hospitals that wanted it. The green dots are the places that we have completed. The yellow dot is one that we at Norton Children's have scheduled for next month. And then the red and the blue dots are the sites that we still are trying to get to fulfill this simulation course with them. For our program here at Norton Children's, we are small but mighty. I have my critical care and transport medicine background. That picture on the right is Dr. Beth Sperlin in the emergency department here, and she is the mass casualty chair, as well as an emergency medicine course physician. The person on the left is Donna Callahan Banks, my senior transport nurse and outreach coordinator on the Just for Kids transport team. And you can see them there pictured in Cynthiana, Kentucky, where the writer of The Walking Dead has several fun artwork around it that we enjoyed when we went to do our outreach there. Our program is a half-day event. The first part uses high-fidelity mannequin simulations, one trauma and one medical, to help teach them more about acute care pediatrics. We follow that up with an equipment and medicine scavenger hunt through the emergency department that matches with the NPRP checklist that the centers are suggested to have for being pediatric ready. Finally, Dr. Sperlin leads a mass casualty tabletop exercise with key stakeholders that the hospital identifies, including their emergency management people, their administrators, their healthcare staff, and any local community people that want to come and be involved. The simulations that we provide include accidental and abusive trauma with and without shock. We've developed a burn scenario as well. From a medical standpoint, we have scenarios in asthma, respiratory failure, sepsis, anaphylactic shock, and rhythm disturbances like SVT. After we're finished, within a couple of business days, we provide them with a site evaluation. First of all, of course, talking about the team strengths that we saw in their journey towards pediatric readiness. We talk about the practical skills that we covered, and those are some examples. And then finally, we do an informal gap analysis as to what things they might need to do to move them on towards pediatric readiness. The most common one that we've identified is having a pediatric surge or disaster plan, or adding an arm to the plan they already have in place that deals with pediatric mass casualty. We leave behind a flash drive that includes some posters that they can print out that have vital signs and equipment sizes for children. We have a series of weight-based code sheets that include resuscitation drugs for patients anywhere from 500 grams to 50 kilos. Dr. Sperlin and I authored a handbook of low-fidelity simulations that include several that they could do on their own with low-cost, locally available medical supplies to try and help more people in their center be able to do pediatric simulations. We also have examples of patient reunification forms that might be helpful for patient tracking, like Angela was talking about. And then we leave behind some articles specifically of the simulations that we performed. We give them posters as well of those vital signs and equipment. And then we leave contact info if they'd like to participate in further pediatric or neonatal simulations with our program back at Children's. In January, we started a Zoomcast, Dr. Sperlin and Morgan Skaggs with EMSC and I, called Office Hours, where we get together the Kentucky Pediatric Emergency Care Coordinators that are part of the grant and see if we can help them on any little details or talk about specific cases or pediatric problems that will help them improve their journey to pediatric readiness. To create an effective experience, it takes both sides of the street. So from the emergency department side of the places we go, really having an engaged pediatric emergency care coordinator and an engaged physician team leader really enhances the learning of the staff. From our side, we try and provide familiar cases that they may see for critically ill children, realistic moulage, and then an organized debrief and recommendations for them to follow. Some of the feedback we've gotten from centers that we've gone to here in the last year have been the addition of signed transfer agreements and roll sheets for their emergency preparedness plans for children. These two centers, as examples, also incorporated the weight-based code sheets in their pediatric assessment areas in the ED. They both have worked on quality improvement projects that were specific to their centers. For example, the timing of treating pain and acute fracture, or always communicating in weight and kilos within their emergency department for children, and several others. So in the future, we would like to create a template that other states could use with our simulation program. There are, of course, also, if you calculate the numbers, 66 more Kentucky hospitals that we could go to help them with their pediatric readiness. The PPN could be a avenue for distributing our simulation handbook to where others wouldn't have to continue to rewrite simulations to provide low-cost low fidelity sims in their partner centers. And then there is a statewide disaster tabletop exercise that we'll be participating here in the spring. That graphic is the table of contents for our simulation handbook. So in summary, Dr. Fowlett described the current state of U.S. pediatric trauma care and discussed the concepts of pediatric readiness for both the pre-hospital and hospital levels of care in our community. The KICS outlined the Kentucky Healthcare Preparedness Program and healthcare coalitions and how it's employed during a disaster response, specifically highlighting the need for patient tracking. Abby went over SciStart as a program that helps to assess and begin treatment for children at risk for PTSD. And then finally, I discussed our pediatric simulation course and program that we've been doing the last year. So here's some of our references, and I'd be happy to stop my sharing and then take any questions that may be needed.
All right, thanks to all of you. Very interesting. For the sake of time, I have one question. So there are 10 hub sites in the United States covering a ton of ground. What's the point of the 10 different hubs? I mean, do you guys just work together as in sharing ideas and as Karen said, like the book of scenarios and simulations? Or do you actually communicate with each other during a disaster? And if you do, what does that look like? What does that entail? What benefit is that for someone in, California to know that we have a disaster in Kentucky?
So I guess I'll take that. The 10 hub sites each have a domain focus, recognizing, again, this is an all hazards grant. When the grant was first announced, it was right at the end of the pandemic, and the intention was for it to be focused on infectious diseases. However, the group that actually was funded took an all hazards approach, and 5 hub hospitals were funded initially, and the second 5 came on with additional funding in the second year of the grant. And now the network is merged. There are, in addition to, for example, we're the trauma burn hub, there are also hubs for education and IT and infectious diseases. And so all of these different domains, the intention is for them to function together to communicate as needed. And then every year we have an annual meeting where we each are provided the opportunity to give reports. But it's not at this point, Mark, a boots on the ground sort of outfit. We also integrate with those ASPR centers of excellence that we didn't really have time to talk about, of which there are 3 now. One along the West Coast, which is where all the fires are, one in the sort of Great Lake area. And then the newest one is down near Texas and southeastern United States, where all the hurricanes are. If you think about where all the tornadoes occur, there is no ASPR Center of Excellence there, but part of the mission of the PPN is to look at climate events and where they occur. And we've actually started to drill down to where trauma occurs during climate events. And we are an at-risk territory not covered by a COE, and perhaps in the future we will be. And so, the other arm of this is to do research by unifying groups that think alike or are doing similar projects, and ultimately to come up with ways to improve preparedness for children all across the country.
All right, good. All right, thank you guys. So thanks everyone for joining us today.